Alright, hi guys. I hope the exam went well, and I got roughly around 22-23 question of pharmacology. So let's quickly discuss and see what all questions were asked and what are the possible answers according to these recall questions that we have got. At any point of time, if you feel that this question or this option was in a different form or different shape, feel free to give your feedback in the comment section. So one question that we are having is about a patient with history of dementia, or they were talking about Alzheimer disease. Which of the following acetylcholine esterase inhibitor is used if patient is not able to tolerate the oral drug? So if you are not able to give oral drug, remember acetylcholine esterase inhibitor, I have told you that we are having GRD, that is known as your galantamine, rivastigmine and donepezil. Galantamine, rivastigmine and donepezil. Undoubtedly, donepezil being the drug of choice, whenever students will see donepezil as an option, they tend to mark. But the question examiner has given here, not able to tolerate. तो rivastigmine के बारे में मैंने बताया था, it's available as a transdermal patch also. So why not give a agent that is available by the transdermal patch rather than waiting for the oral drug? Oral तो वैसे भी ये tolerate नहीं कर पा रहा है, so it's better to give a transdermal patch, right? So I hope कि all of you guys have got this one. Rivastigmine is going to be the correct answer for this one, right? Next one. About a 26-year-old patient with a history of Mycobacterium tuberculosis was started on anti-tubercular agent. 6 months later, the patient presented with symptoms like neck swelling. Okay, so neck swelling, increased TSH level, that is actually a characteristic feature of your hypothyroidism. In simple word, अगर examiner चाहता तो पूछता which of the following anti-tubercular causing hypothyroidism. तो दो ड्रग के बारे में मैं मेंशन करता हूं इन द क्लास दैट इज एक्चुअली एसोसिएटेड विद द हाइपोथायरॉयडिज्म. दे आर एसोसिएटेड विथ योर इन द एंटी ट्यूबरकुलर ड्रग बाय द नेम ऑफ इथियोनामाइड, and another agent is para-aminosalicylic acid. The first ever anti-tubercular drug is para-aminosalicylic acid. वो भी कर सकता है ethionamide. Among the given choices, guys, ethionamide is the correct answer. Cycloserine, if you see, cycloserine, many of you have marked cycloserine, cycloserine. मैं कैसे लिखता हूँ क्लास में इसको? जानबूझ के मैं इसको लिखता हूँ साइकसेरिन, जो आपको साइकेट्रिक बना दे. ये ऐसा है सेरिन, साइकसेरिन. पायराजिनामाइड, प्यारजिनामाइड, एंड प्यार से रिलेटेड आई हैव टोल्ड यू 5-6 पॉइंट दैट प्यार का डोज इज ऑलवेज हाईएस्ट. सो अमंग द फर्स्ट लाइन ड्रग द डोज इज हाईएस्ट. सेकेंड थिंग दैट इज टू टेल you that pyar should be avoided during pregnancy में इसको avoid करना है according to FDA. Third thing they used to tell you that pyar is very very toxic in life, most hepatotoxic agent. pyar दर्द भी देगा, that is another thing that I used to tell you. That means they are going to increase the uric acid level, can precipitate gout, है ना. And apart from that, I also used to tell you that pyar priyanka से करना है तो PNCA gene will be causing resistance of the pyrazinamide. Rifampicin, red orange urine discoloration, hepatotoxicity are the important side effect. Flu-like symptom, again on the intermittent dosing can be seen. Among the given choices, ethionamide is the correct answer for this question. Next one. A patient was started on doxorubicin, cardiotoxicity can be seen. So doxorubicin, daunorubicin, in fact जितने भी एंथ्रासाइक्लिन वाले ग्रुप हैं, they all can cause cardiotoxicity, है ना. एंड उसको प्रिवेंट करने के लिए वी आर गोइंग टू यूज एन आयरन चीलेटर एजेंट, एंड द आयरन चीलेटर दैट वी आर गोइंग टू यूज इज नोन एज डेक्सराजॉक्सेन. अगर आपको याद होगा तो कीमोमैन वी यूज टू डिस्कस इन द क्लास, एंड इन दैट कीमोमैन आई यूज टू टेल यू दैट देयर आर डिफरेंट टाइप ऑफ ड्रग दैट इज कॉजिंग टॉक्सिसिटी. Doxorubicin, daunorubicin will be causing cardiotoxicity, and to prevent the cardiotoxic event, we are going to add dexrazoxane. So you can easily see dexrazoxane is the correct answer. So this one question is directly taken from this chemoman. In the previous examination of 2022, they have asked bleomycin or busulfan mediated pulmonary fibrosis, which drug is used to prevent? So perfenidone was the answer for that one, right? अगर आगे क्वेश्चन ये पूछ ले साइक्लोफॉस्फेमाइड, आइफॉस्फेमाइड, दे विल बी कॉजिंग हेमोरेजिक सिस्टाइटिस, राइट, और हेमोरेजिक मायोकार्डियल नेक्रोसिस. इन दैट केस सिनेरियो आईवी मेसना विल बी यूटिलाइज फॉर हेमोरेजिक सिस्टाइटिस प्रिवेंशन के लिए. आईवी मेसना वी आर गोइंग टू यूटिलाइज, राइट. ल्यूकोवोरिन, फोलिनिक एसिड विल बी यूटिलाइज फॉर रिड्यूसिंग द टॉक्सिसिटी ऑफ methotrexate. I hope all of you guys have got this one, but this question was very very easy. Let's look at the other option here. Aprepitant, rolapitant, netopitant, what are they? They are the neurokinin or substance P antagonist, right? They are given for delayed nausea and vomiting. Amifostine, they are nephroprotective agent. They are also radiosensitizing agent. They are used to prevent the nephrotoxic event by your cisplatin. Leucovorin, as I told you, also known as folinic acid, is going to prevent the toxicity of methotrexate. I hope all of you guys are getting this one. Please feel free to comment at any point of time if you feel वो क्वेश्चन का लैंग्वेज अलग था, बिकॉज ये सारे के सारे रिकॉल बेस हैं. और एक बात मैं आपको और बता दे रहा हूँ कि मतलब जब से आपका एग्जाम खत्म हुआ, वी आर कंटिन्यूसली इन टच विद द स्टूडेंट, एंड दिस इज द बेस्ट फॉर्म ऑफ क्वेश्चन दैट आई कुड कम अप विथ फॉर ऑल ऑफ यू गाइस. ओके, चलते हैं अगले क्वेश्चन के बारे में. So this is one chemo man is always all time favorite and always very important. A patient is on mood stabilizer now presenting with the red हेपेटिक एंजाइम्स एंड हाइपरअमोनीमिया. कभी भी मोस्ट हेपेटोटॉक्सिक, एंटी एपिलेप्टिक और मूड स्टेबलाइजर की बात करेंगे तो इट्स ऑलवेज गोइंग टू बी योर सोडियम वैल्प्रोएट. सोडियम वैल्प्रोएट अनडाउटेडली इट्स वन ऑफ द एंटी एपिलेप्टिक ड्रग. Do you guys know in a patient with a rapid cycler it is also considered as a drug of choice? So जो bipolar disorder वाले patient होते हैं in that rapid cycler phase if the episode is more than 4 in 1 year we call them rapid cycler. उसमें भी drug of choice है and it's highly hepatotoxic. So anti-epileptic drug causing hyperammonemia or CNS like symptom because of the increased liver enzyme है ना, definitely it's going to be your sodium valproate. Next question, in a female with a history of bleeding manifestation, okay, so there is a bleeding manifestation, petechial rashes, heavy menstrual bleeding and easy bruising. This was the language that many students have said. Now if you guys feel that इसका language थोड़ा अलग था या इसका language should be different, then please feel free. I am just checking your comments here also. And feel free to reply in the comment section. There is a live chat option that you guys can actually utilize to give your feedbacks here. Which of the following tyrosine kinase inhibitor? So actually the possible diagnosis here where the examiner is asking ITP. I'm not pretty sure whether ITP was directly given in the option, but अगर ये clinical manifestation के बाद पूछ रहा है कि कौन सा tyrosine kinase inhibitor यूज करेंगे तो we are going to use fostamatinib. Fostamatinib is the one that we are going to use. Bosutinib guys, it's a second generation tyrosine kinase inhibitor that can be utilized in a patient with the CML. ठीक है. आइसोलेटेड थ्रोम्बोसाइटोपेनिया, अगेन अगर थ्रोम्बोसाइटोपेनिया दिया हुआ तो अगेन इट इज अगेन गोइंग टू बी इडियोपैथिक थ्रोम्बोसाइटोपेनिक परप्यूरा. आइसोलेटेड थ्रोम्बोसाइटोपेनिया, ठीक है. फोस्टामैटिनिब, राइट, वी हैव डिस्कस्ड इन हेमाटोलॉजी चैप्टर. अगर आप देखोगे तो जहां पे मैंने हेमाटोलॉजी का लास्ट ब्लड फॉर्मिंग ड्रग्स बताया वहां पे मैंने इसको डिस्कस किया. फोस्टामैटिनिब कैन बी यूटिलाइज्ड. नो व्हाट इज रोमिप्लास्टिम? इट इज वन ऑफ द रोमिप्लास्टिम, इट इज वन ऑफ द प्लेटलेट स्टिमुलेंट. रोमिप्लास्टिम इज द प्लेटलेट स्टिमुलेंट. तो कीमो इंड्यूस अगर थ्रोम्बोसाइटोपेनिया तो उसमें यूज करेंगे. एग्जामिनर ये पूछा है विच टायरोसिन काइनेज इनहिबिटर. देखिए जितने भी टायरोसिन काइनेज इनहिबिटर होते हैं उनके नाम में देयर विल बी निब. So as soon as you know this information, two options are all ruled out. Oprelvectin, it's one of the interleukin 11 agonist. We can also utilize this one, romiplastin or oprelvectin, to increase the level of platelets, but they are not tyrosine kinase inhibitor, right? Interleukin 11 agonist and romiplastin, they are the thrombopoietin receptor agonist. Thrombopoietin agonist. All right. So correct answer for this one is going to be fostamatinib. Which of the following anti-diabetic agent is approved for the heart failure patient with reduced ejection fraction? Now, was this question in the same language or there was some different language? Feel free to give in the comment section, guys. All of you guys, Dr. Tikhi Puri, Medicos, Anugya Rima, and all the other students, है ना, feel free to reply. Because अगर ये question है कि anti-diabetic agent and option में liraglutide है, degludec है, degludec actually is a insulin. इट इज द लॉन्गेस्ट एक्टिंग इंसुलिन. मैं कैसे बताता हूं? देर तक चलने वाला इंसुलिन. देर तक चलने वाला इंसुलिन डिग्लूडेक है. लॉन्गेस्ट एक्टिंग, कैन लास्ट फॉर अप टू 42 आवर्स. तो अगर कोई पेशेंट आपके पास आता है जिसमें आपको लंबे समय के लिए इंसुलिन का लेवल को मेंटेन करके रखना है, प्लेटू मेंटेन करके रखना है, तो वी कैन यूटिलाइज दिस वन. कैनाग्लिफ्लोजिन, डेपाग्लिफ्लोजिन, वॉज इट देयर? कैनाग्लिफ्लोजिन, डेपाग्लिफ्लोजिन, इट इज वन ऑफ द SGLT2 इनहिबिटर. एक और SGLT2 इनहिबिटर है जिसका नाम होता है एम्पाग्लिफ्लोजिन. गाइस रिमेंबर, एम्पाग्लिफ्लोजिन इज वन ऑफ द एजेंट दैट हैज बीन आल्सो अप्रूव्ड फॉर कंजेस्टिव हार्ट फेलियर पेशेंट. ये CHF पेशेंट में ये भी अप्रूव हुए हैं, ठीक है. लेकिन क्या ये ऑप्शन में था? ये ऑप्शन में था कि नहीं था? और डॉक्टर तीखापुरी, लीराग्लिप्टिन नहीं होगा. अगर होगा तो लीनाग्लिप्टिन होगा. लीराग्लिप्टिन कोई ड्रग नहीं होता है. और पायोग्लिटाजोन, रोजिग्लिटाजोन, अगर रोजिग्लिटाजोन था तो अगेन दैट इज नॉट अप्रूव्ड फॉर द हार्ट फेलियर पेशेंट. वाज लीराग्लुटाइड इज देयर इन ऑप्शन और नॉट? लीराग्लुटाइड, जस्ट गिव मी टू ऑप्शन. अगर लीनाग्लिप्टिन था तो लीनाग्लिप्टिन विल नॉट बी प्रिफर्ड फॉर हार्ट फेलियर पेशेंट. लीराग्लुटाइड है. तो मैं आपको इंफॉर्मेशन दे रहा हूं, आप खुद डिसाइड कर लेना. अगर एंटी डायबिटिक ड्रग की बात करता है, एंटी डायबिटिक एजेंट फॉर हार्ट फेलियर, दो ड्रग का नाम सबसे ऊपर आता है. एक का नाम आता है लीराग्लुटाइड, GLP-1 एनालॉग, लीराग्लुटाइड, और दूसरे का नाम सेकंड नंबर पे आता है एम्पाग्लिफ्लोजिन। अगर इन दोनों में से जो था, दोनों ऑप्शन में तो हो नहीं सकते, दोनों में से कोई एक होगा। अगर लीनाग्लिप्टिन था तो वो भी ऑप्शन आंसर नहीं होगा। ऑन द टॉप आई हैव रिटन एंटी डायबिटिक एजेंट दैट इज अप्रूव्ड फॉर द हार्ट फेलियर, लीराग्लुटाइड, एम्पाग्लिफ्लोजिन। दोनों नहीं होगा, दोनों में से कोई एक होगा, और जो भी होगा वो करेक्ट आंसर होगा। नाउ सम ऑफ यू आर टेलिंग मी हियर दैट एम्पाग्लिफ्लोजिन वाज देयर इन द ऑप्शन, सो दैट इज गोइंग टू बी द करेक्ट आंसर ऑल्सो। अब जितने बच्चे इसको रीनल फेलियर वाले से कंफ्यूज हुए हैं उनको मैं बता दे रहा हूं, उनके साथ इशू ये हुआ है बिकॉज PYQ में एक क्वेश्चन आया था कि विच ऑफ द फॉलोइंग DPP4 इनहिबिटर दैट इज गोइंग टू बी सेफ इन रीनल फेलियर। DPP4 इनहिबिटर सेफ इन रीनल फेलियर। देखिए उस कंडीशन में योर आंसर विल बी नन अदर देन योर लीनाग्लिप्टिन। उस कंडीशन में योर आंसर विल बी नन अदर देन लीनाग्लिप्टिन। सो यहां पे तो सेफ इन रीनल फेलियर सिर्फ डायबिटीज के लिए नहीं पूछ रहा है ना, यहां पे हिस्ट्री डायबिटीज के लिए था, या क्वेश्चन पूछा हुआ था कि हार्ट फेलियर में यूज करेंगे। वॉज इट फॉर हार्ट फेलियर, वॉज देयर हिस्ट्री ऑफ हार्ट फेलियर? अगर हार्ट फेलियर है तो उसका आंसर नन अदर देन एम्पाग्लिफ्लोजिन होगा। आई होप इट इज मेकिंग सेंस टू ऑल ऑफ यू गाइस। लीराग्लुटाइड, जैसे कि सारे बच्चे बोल रहे हैं सर लीराग्लुटाइड नहीं था, देन आई एम कंसिडरिंग लीराग्लुटाइड नहीं था तो डेफिनेटली लीनाग्लिप्टिन होगा। लीनाग्लिप्टिन इज गोइंग टू बी द नेक्स्ट बेस्ट। मैं लिख दे रहा हूं यहां पे लीनाग्लिप्टिन अगर था तो ये आंसर नहीं होगा। अगर हार्ट फेलियर के लिए भी पूछ रहा है, हार्ट फेलियर के लिए कौन सा यूज करेंगे विद रिड्यूस्ड इजेक्शन फ्रैक्शन, प्लीज गिव मी ए क्विक कंफर्मेशन, क्या रिड्यूस इजेक्शन फ्रैक्शन था या नहीं था? बस इतनी सी बात है। अगर इतनी सी बात है और एम्पाग्लिफ्लोजिन ऑप्शन में है तो ये करेक्ट आंसर होगा, इसका कोई अल्टरनेटिव नहीं है। हार्ट फेलियर विद रिड्यूस इजेक्शन फ्रैक्शन विद रीनल फेलियर, एम्पाग्लिफ्लोजिन विल बी द प्रिफर्ड वन। ठीक है। एंटी डायबिटिक ड्रग फॉर हार्ट फेलियर में दो ड्रग का नाम हमेशा ऊपर आता है, लीराग्लुटाइड, एम्पाग्लिफ्लोजिन। जो बच्चे कंफ्यूज हुए हैं वो उसमें DPP4 इनहिबिटर सेफर इन रीनल फेलियर, उस कंडीशन में लीनाग्लिप्टिन इज द करेक्ट वन, लेकिन हार्ट फेलियर में वो उसका अप्रूवल नहीं है। आई होप इट इज मेकिंग सेंस टू ऑल ऑफ यू गाइस। Sorry if it is getting wrong, but this is the best way to get this one. Okay, next one. Which of the following is not seen with TCA toxicity? TCA, amitriptyline, imipramine, trimipramine, है ना? TCA toxicity में confusion होगा। They are having anticholinergic effect, because of that there will be blurring of vision भी होगा, तो pupillary dilatation can lead to blurring of vision. They are also having alpha-1 blocking property, because of that there can be arrhythmia as well, but hypothermia तो reported नहीं है ना, hypothermia reported नहीं है। Next, upcoming examination में they can ask you what could be the possible antidote, तो इसका कोई antidote तो available नहीं है। Then since this is going to cause metabolic acidosis, it will be associated with the metabolic acidosis, we are going to cause फोर्स्ड अल्कलाइन डायूरेसिस। अगर आपको याद होगा तो 2022 का ये क्वेश्चन था, है ना, कि फोर्स्ड अल्कलाइन डायूरेसिस विल बी डन इन विच ऑफ द फॉलोइंग। सो क्वेश्चन टॉपिक ऑलमोस्ट सेम है, बस थोड़ा सा लैंग्वेज को चेंज कर दिया। तो फोर्स्ड अल्कलाइन डायूरेसिस यूजिंग सोडा बाइकार्ब विल बी द करेक्ट आंसर फॉर दिस वन। हाइपोथर्मिया विल नॉट बी वन ऑफ द सिम्टम हियर। नेक्स्ट वन, which of the following protease inhibitor can maximally produce hepatotoxicity? Was there a question something like this, that जितने भी प्रोटीएज इनहिबिटर होते हैं they are all ending with the navir? Please give a quick confirmation, was this question there or not? प्रोटीएज इनहिबिटर ending with the navir, और जितने भी नावीर होते हैं, मैं आपको एक सिंपल सा स्टोरी भी सुनाया था कि जब भी GI पे HCl आता है, GI यूजुअली ब्लीड करता है, GI bleeds with HCl. GI related side effect is the most common side effect where the patient will have nausea, vomiting, diarrhea. Bleed मतलब there is gonna be bleeding risk. Bleeding risk that is going to be maximally with your tipranavir and ritonavir in the same order. Tipronavir and ritonavir in the same option. ठीक है। Was there a history of headache also and confusions? कुछ CNS effect है क्या पेशेंट को in this one? Even if the option is having, let's say, lopinavir, ठीक है, क्या ये ऑप्शन सही है? टिप्रानावीर, सेक्विनावीर, अटाजानावीर, नल्फीनावीर, लोपिन, चार ही होंगे कोई भी? रिटोनावीर वाज देयर, hepatotoxicity. Yes, I'll be using English. Sorry, vision mission. Yes, I will be. Hepatotoxicity, cardiac conduction abnormality is going to be the another side effect. Cardiac conduction abnormality, this is going to be maximally seen with your sequinavir, and they can even lead to lipodystrophy syndrome. Lipodystrophy syndrome, metabolic derangement, these are going to be the important side effect. Okay, so some of the students are saying ki sir there was ritonavir also. All right, ritonavir is the most potent enzyme inhibitor that we have. And was there tipranavir, ritonavir both? Was there tipranavir, ritonavir both? If ritonavir was there in the option, I hope all of you guys have got with ritonavir. If ritonavir was there in option, please go ahead with the ritonavir. If it was there, then ritonavir. It's the one that is having maximum enzyme inhibiting property. Also, it is having maximum risk of hepatotoxicity as well. Ritonavir ke saath, please proceed with ritonavir. Next one. Now look at this question very carefully. This question was discussed with many students here. There is a patient who is on multi-drug resistant TB therapy. He is presenting with multiple joint pain. So multiple joint pain, I just gave you a story of pyrazinamide, and I told you PAR is very toxic. Most hepatotoxic is pyrazinamide. Then I told you PAR dard bhi dega, PAR will give you pain as well, so they can precipitate gout. So that is exactly what has happened. Most hepatotoxic and pain inducing is going to be your pyrazinamide, pyrazinamide, and they have also altered liver enzyme, but the liver enzyme is not altered that much. Liver enzyme is not altered that much, increased hai. Let's say if the liver enzyme is considered up to 35, 38 normal, there is slight increment for up to 55, है ना, up to 33, 34 या up to 35 it is considered normal. ठीक है. Next line of management. Now in a country like India, where the most important problem is going to be TB, look at the other option. Stop all and monitor uric acid and start the level when once the level become normal. See, in any mycobacterium treatment, be it leprosy or be it TB, stopping the therapy is not advised initially. Whenever we are trying to give multi-drug resistant therapy, or whenever we are trying to use any TB therapy, always and always remember that stopping the drug is not the option. We always ask to follow up. Kabhi bhi, whenever there is any problem, ask the patient to follow up. Stop only pyrazinamide and monitor uric acid and AST, ALT. Stop all hepatotoxic and monitor liver enzyme. Continue all and add uric acid lowering drug. Do you guys think that option was there? These options were there, the option that I have used here. The option, do you think these options are correct in the same order, or there were some language changes? The question says here next line of management. I hope it was same, next line of management. In the given scenario, when the examiner is asking what will be the possibly next line of management. Now, if you are going to look for the international guideline, and according to Goodman-Gilman, whenever they are saying, let's read what Goodman-Gilman has to say. Let's read what Goodman-Gilman has to say. This is the screenshot from the Goodman-Gilman. They are telling something very important. Along with me, please rewind. Prior to pyrazinamide administration, all patients should undergo a hepatic function LFT test. Next line, it's saying if there is evidence of significant hepatic damage, therapy must be stopped. Therapy must be stopped. This is according to the international guideline, and this is also according to our Goodman-Gilman. Pyrazinamide should be avoided in individual with if there is alteration in hepatic baseline enzyme. Let's say your patient is coming today and you are going to start an anti-tubercular drug, and you found out that okay, the hepatic enzyme is already altered from the baseline. In that case scenario, you will not be starting. But they have not mentioned anything like this. They are telling ki you have already started the therapy, and after starting the therapy, now there is a precipitation of the gout. The main problem here is the precipitation of the gout here. Pyrazinamide should be avoided in individual with baseline hepatic dysfunction. If pyrazinamide cannot be used at any point of time, if you cannot use it, Short course of rifampicin, isoniazid and ethambutol can still be successfully used, but here the duration can be prolonged from 6 months to 9 months. If it is first line drug, you can increase the duration from 6 months to 9 months. Okay. Next line it's saying, in almost all the patient, in almost or nearly all patient, pyrazinamide exhibit excretion of urate, inhibits excretion of the urate resulting in hyperuricemia, which may cause precipitation of the gout. What is the main problem here for your patient? The main problem for your patient here is the precipitation of the gout, and in that case scenario, it is always advised usually to add a urate lowering drug and continue the same. In a country like ours, in a country like India, we do not ask the patient to stop a drug, है ना? So continue all and add uric acid lowering drug if that is the option that is given here, because again, if there is a concerning level of, or if the level is very much high, let's say the level is going 500 or 800 or 1000, in that case scenario we are bound to stop. But ALT AST is just slightly high, so we are going to continue the drug that we have, and after continuing the drug we are going to add the uric acid lowering drug. I hope it is making sense to all of you guys. Next one. A 55-year-old male patient with history of hypertension and occasional spikes of blood glucose. Which of the following is the most preferred agent? Was there a question something like this, guys, that there is a patient of hypertension coming to you, age is 55. So according to the NICE guideline, whenever we try to start the anti-hypertensive drug, we look for the age, right? And whenever the age is less than 55 or more than 55, more than or equal to 55, right? If the age is less than 55, we start A or A. A or A means either ACE inhibitor or ARB. This is what we are going to start, A or A, either ACE inhibitor or ARB. If the level is more than 55, then age is more than 55, then we are going to start C or D. C or D. What is C? C is calcium channel blocker, D for diuretics, right? So in this case scenario where the patient is coming to you with the 55-year and there is a history of hypertension and you have to start one drug, and now you have to start one drug. So first line drug हमेशा start करेंगे ना usually. What is the first line drug that we have? The first line agent that we are having, C or D. C is the calcium channel blocker. C is calcium channel blocker. D is diuretic. Diuretic, preferably thiazide. These are the first line drug. So exercise plus amlodipine is something that you can start actually. Exercise plus calcium channel blocker. ठीक है? Was there an option something like this? या ऑप्शन थोड़ा ऊपर नीचे था? ऑप्शन ठीक है इन द क्वेश्चन लाइक दिस? अगर ऑप्शन में कुछ चेंजेस हैं, इफ यू फील द ऑप्शंस आर समथिंग एल्स, प्लीज फील फ्री टू मैसेज, आई विल टेक अप ऑल द क्वेरीज. लेट्स टेक द नेक्स्ट वन. दिस इज वन ऑफ द PYQ, पुराना क्वेश्चन से उठाया हुआ क्वेश्चन है ये. All of the following are side effect. All of the following side effect are more common with carbamazepine than oxcarbazepine except. ठीक है? All of the following side effects are more common with carbamazepine than oxcarbazepine except dilutional hyponatremia. Do remember dilutional hyponatremia that we have. Dilutional hyponatremia is going to be more common with oxcarbazepine, right? More common with oxcarbazepine. जयप्रकाश इज आस्किंग व्हाई नॉट सी. डॉक्टर मैंने जैसे कि बताया ना कि जब भी whenever you are going to start anti hypertensive drug, we start according to guideline. So if the age is less than 55 or more than 55, that is our cutoff for according to NICE guidelines. So we are going to start either ACE inhibitor, ARB. If the age is more than equal to 55, we are going to start either calcium channel blocker or diuretics. So metoprolol is one of the beta blocker, and beta blocker is among the second line anti-hypertensive drug. Is among the second line. So if you have to start one, I would say start with amlodipine. If this is the exact question of the examiner. ठीक है? Now, let me just give you what Goodman-Gilman has to say here. Goodman-Gilman very clearly says that although most adverse effects are similar to those of the carbamazepine, oxcarbazepine, although most side effect of oxcarbazepine is pretty similar to carbamazepine, hyponatremia that we have may occur more commonly with oxcarbazepine. And other side effect, dilutional hyponatremia is more common. Other side effect is lesser. जो oxcarbazepine है, it is having lesser, let's say, bone marrow suppression, and it's having lesser CNS effect, है ना? Apart from that, lesser risk of rashes, hypersensitivity reaction, but oxcarbazepine has more risk of dilutional hyponatremia, and they are more common with they are more common in elderly population. They are more common in elderly patient. So this is one of the direct question. Option is only hyponatremia. Agar hyponatremia, then it's still same. If dilutional was not there, then there is nothing to worry. Hyponatremia again going to be more common with the oxcarbazepine, right? So D is the correct answer. Hyponatremia, the word is hyponatremia is more common with the oxcarbazepine. This hyponatremia is because of the ADH only, so isliye I use the term dilutional hyponatremia. Okay, so Dr. Harish, you are absolutely correct. Next one. A 60-year-old farmer presented with the fever, body ache and cough. So there were some non-specific symptom. Upon examination, there was a black spot on the chest as shown in the image. The image is not here. I think due to some PowerPoint setting, the image is removed from here. But even if there is no image, look at the line of the question. There is a positive evidence of IgM for scrub typhus. Positive evidence of IgM. तो ऑलरेडी डायग्नोसिस हो गया ना, देयर इज ऑलरेडी डायग्नोसिस दैट देयर इज डायग्नोसिस ऑलरेडी स्क्रब टाइफस. सो इन दैट केस सिनेरियो द बेस्ट ड्रग अगर आप देखने चाहते हैं और द ड्रग ऑफ चॉइस इफ यू आर गोइंग टू सी, देन वी आर हैविंग डॉक्सीसाइक्लिन, right? Preferred treatment. Now if you have to choose between doxycycline alone or doxy plus azithro, remember there are a certain group of people who are actually resistant to doxy. In that case scenario, you cannot just rely in this patient and you just give doxy alone. I would strongly recommend that go ahead with the doxy and azithromycin combination. Okay, doxy and azithromycin combination is the best. Now look at the language of the question. Does it say best treatment modality, preferred treatment modality या सिंगल बेस्ट ड्रग ऑफ चॉइस पूछा था? आजकल के टाइम पे इन टूडेज टाइम दे आर नॉट यूजिंग द टर्म ड्रग ऑफ चॉइस बिकॉज अगेन ड्रग ऑफ चॉइस इज कीप ऑन चेंजिंग. नाउ द मोस्ट बेटर term is P drug. P drug is preferred drug, and on the term of P drug already there was a question in the previous NEET PG examination and FMG examination as well. In this scenario, if there is a question like this, I would strongly say I would be going ahead with the doxy with azithromycin. There are a group of people, those who are resistant to doxy, so we cannot just give doxy and rely alone. If both are given, preferred is always going to be a combination of both. Okay? Preferred is always going to be a combination of doxy plus azithromycin. Definitely, if it is INI-CET, it is supposed to be tricky and it cannot be just easy. 1 to 2 question definitely are very easy, जैसे कि that oxcarbazepine वाला question. Ceftriaxone is not effective, doctor. If IV ceftriaxone is given, ceftriaxone is not for scrub typhus. It's a cell wall inhibitor. It's not effective for your scrub typhus. Scrub typhus के लिए single drug, if you are going to choose single drug, it's going to be doxycycline. But if you have to choose doxy alone and doxy plus azithro both, I would be saying that according to the recent treatment guidelines also and the clinicians also, they are preferring more doxy plus azithro का combination because of the different pattern of resistance. A 28-year-old male presented with altered sensorium and pinpoint pupil. So pinpoint pupil, I always used to say that, remember, pinpoint pupil will be seen in POMP. And so pinpoint pupil can be seen in pontine hemorrhages. It can also be seen in organophosphate poisoning, carbamate poisoning, carbamate poisoning, morphine poisoning. Sometimes they use the term opioid. Again, morphine is opioid only. Also in the phenol poisoning. So this is a very direct question, guys. You can consider this as a forensic question, consider this as a pharma question. It's hardly matter, and I'm pretty sure all of you guys have marked morphine here. Cocaine, it is a NET inhibitor, NET, norepinephrine reuptake inhibitor. So it is going to increase the level of norepinephrine. So there will be a mydriasis. Amphetamine is also sympathomimetic. Likewise, dhatura will be causing your mydriasis also. So among the given choices, opioid, opioid ka nasha, definitely morphine will be causing pinpoint pupil. Next one. Okay, now this was a little tricky one and it took some time for me to formulate this question, and thank you very much for all the students for staying in consistent touch and completing all these questions. All thanks to all the students, those who are listening to me, watching me, or even those who are going to watch me later on the recorded session, that you guys have been consistent and have been patiently, replying to all the queries that I have been raising here. So site of action of valproate. Was there a question something like this, boys and girls? Was there a question something like this, site of action of valproate? A, B, C, D. So there are 4 sites here. A here is given only at the GABA transaminase. B here is given SSA dehydrogenase and GABA transaminase both. C here is possibly GABA reuptake inhibitor, and D here directly at the GABA, a receptor. If there was a question something like this, and they are asking what is the site of action of valproate. See, valproate directly, it's one of the voltage gated sodium channel blocker. Okay? It's a voltage gated sodium channel blocker. In addition to that, it is also having GABAergic property, so they can increase the GABA level as well. The GABA level increment by valproate is by two important mechanisms. The correct answer here is this one, B. Let us see what Goodman-Gilman has to say about this one, right? That how valproate can increase the GABA. Here there is a quick screenshot from Goodman-Gilman that valproate can stimulate the activity of GABA enzyme, right? Valproate can stimulate the activity of GABA synthetic enzyme, glutamic acid decarboxylase, and inhibit GABA degradative enzyme. They are going to inhibit the degradative enzyme of the GABA by the name of GABA transaminase and SSA, that is succinic semi-aldehyde dehydrogenase. So they are increasing the level of GABA by two important mechanisms, and one is GABA transaminase inhibition, definitely a specific drug that is GABA transaminase inhibition, right, is known as vigabatrin. Vigabatrin पे भी question आ चुका है 2020 aims में. Vigabatrin, it's one of the GABA transaminase inhibitor, but valproate can also increase GABA by two important mechanisms. One is GABA transaminase and also SSA inhibition. SSA मतलब your succinic semi-aldehyde dehydrogenase. SSA is succinic semi-aldehyde dehydrogenase. I hope all of you guys have got this one. And here the arrow, look at the arrow how they have given. A only targeting at GABA transaminase, B targeting succinic SSA dehydrogenase and GABA transaminase B, C is inhibiting the reuptake, D is directly acting at the receptor. I would say go ahead with the B. B का जो है, right? B का site is the most appropriate, that they are inhibiting SSA dehydrogenase, succinic dehydrogenase and GABA transaminase. Yep. Yes, Dr. Metroid, definitely you are absolutely right. Okay, next one. A child was brought with a history of iron tablet intake. Treatment of with desferoxamine is started. So iron poisoning is all-time favorite, है ना? So they are always asking. Previously they asked that oral क्या देंगे? So oral antidote is known as deferiprone and deferasirox. Last time they asked. Topic is again going to be same, guys. Deferasirox. This time they didn't ask. They asked at which iron level will be starting the treatment. So we are going to start the treatment in level beyond more than 500. Treatment of deferoxamine is started at this level. More than 500 pe we will be immediately starting the treatment. So this was a direct question, number based question. Next one. Diabetic neuropathy and spinal cord injury. So if there is a neuropathy, guys, pregabalin, gabapentin, gabapentin, it is one of the N-type calcium channel inhibitor. Pregabalin, gabapentin, N-type calcium channel blocker. They are considered the drug of choice in all the neuropathic pain. They are the drug of choice in neuropathic pain. It can be post-herpetic neuralgia. Post-herpetic neuralgia. It can also be diabetic neuropathy. In any type of neuropathic pain we can utilize, including sciatica. Remember, it's also preferred in a patient with the restless leg syndrome. RLS matlab restless leg syndrome mein bhi also we can utilize. It's also a drug that can be utilized for the prophylaxis of migraine. Since I discussed this in epilepsy chapter, we remember it can also be utilized in focal seizure as an add-on drug. Focal seizure or partial seizure maybe also we can utilize them. So correct answer for this question is going to be your pregabalin. Do you guys remember the other option here? Do you guys remember other option here? Sumaya Fatima, deferiprone, deferasirox, you are going to use orally. They are the orally effective iron chelator. So whenever there is a patient with a history of thalassemia with a recurrent blood transfusion, look at the term, patient with thalassemia history, recurrent blood transfusion, in that case scenario, we will be continuously adding deferiprone, deferasirox so that we can prevent the iron overload. Emergency scenario mein we are always going to use deferoxamine. Okay. If you guys remember other option here, dark night, was there carbamazepine option here? Post herpetic neuralgia यहाँ लिख दिया मैंने. If carbamazepine was option there, carbamazepine can be utilized, but again preferred is drug of choice is always going to be pregabalin or gabapentin. Next one, let's see. Which of the following pathogen is not sensitive to the shown drug? So they have given different pathogens here like Aspergillus niger, Candida krusei, Candida glabrata and itraconazole. This is a question also directly taken from Goodman-Gilman, and this is a PYQ also. It's one of the PYQ also. It's a previously asked question as well. Do remember that. Amitriptyline was given in the options. Amitriptyline definitely can be used in neuropathic pain, but if you have to prefer one, I would say go ahead with the pregabalin. If amitriptyline was given, still pregabalin will be the correct answer. Neuropathic pain mein we can use amitriptyline, है ना, but we are going to use the most preferred, that is pregabalin. Okay. Alright, so as I was telling to all of you guys, aspergillosis mein the drug of choice is voriconazole. Voriconazole is the drug of choice. Drug of choice for candidiasis, guys. Drug of choice for candidiasis is going to be fluconazole, but two different species of candida is known as Candida krusei and glabrata. Look at what Goodman-Gilman clearly said, and paragraph se directly उठाया question है. They have taken the question directly from the paragraph that Candida glabrata and krusei are considered intrinsically resistant to fluconazole. End of conversation. They are resistant, and whenever there is a fluconazole resistant, in that case scenario, in resistant cases, we are going to prefer amphotericin B. In that case scenario, fluconazole will not be utilized. Amphotericin B is going to be a preferred agent, right? So Candida krusei, fluconazole, again they are not sensitive. They are not sensitive. Glabrata, amphotericin B, yes, we can utilize. Itraconazole, sporothrix, again they are the drug of choice, है ना? Itraconazole is the drug of choice in HSB. B stand for your blastomyces. S stand for your sporothrix, and histoplasmosis, histoplasma. ठीक है. So HSB में your itraconazole is the drug of choice. It's one of the azoles. Okay. Candida krusei and glabrata, they are resistant to fluconazole. For all others, Candida, fluconazole is the drug of choice. We can take one more question here. We are having 75-year-old patient with congestive heart failure and cardiac enlargement. Please vouch here. Give me a quick feedback. That was there a question about a patient? Was there a question about a patient having congestive heart failure and cardiac enlargement? Which of the following will decrease the mortality and reduce the further enlargement? Was the language something like this, or was the language something else? Options are digoxin, furosemide, captopril, carvedilol. About a 75-year-old patient, congestive heart failure. Now, drugs reducing mortality. Drugs reducing mortality. I used to tell you that, remember, like as simple as we are having ACE inhibitor, ARB, aldosterone receptor blocker. ARB matlab all the sartans. Tell me sartan, losartan. All the pril like ramipril, lisinopril. ठीक है. Then we are also having ARNI. ARNI is a combination of ARB, है ना, telmisartan plus neprilysin inhibitor. Telmisartan plus neprilysin inhibitor. Telmisartan plus neprilysin inhibitor, that is sacubitril. So they are not used alone. Sacubitril को हम alone नहीं use करते हैं. We are going to use them in combination with telmisartan. We collectively call them ARNI. ARNI is this one, a combination of ARB plus neprilysin inhibitor. Then we are also going to use beta blocker, है ना. Beta blocker में याद रखिएगा, low dose में we are going to start low dose beta blocker, and then we can also use some of the important dilators. For example, your potassium channel opener hydralazine, nitrates, they are the dilators, and currently they are telling that your drugs like your SGLT2 inhibitor like empagliflozin can also have this, empagliflozin can also have this reducing mortality property. Now in this scenario, if you are going to look at this one, I am telling you that lot of A are there, no? Lot of A are coming, B is coming, dilators are coming, right? Now in this scenario, definitely there is one option that is by the name of captopril and carvedilol. Two options are there given here, guys. Look at the language of the question. Very tricky question. Decrease mortality. In that case scenario, decreasing the mortality can be done by both C and D. But the problem is, are we using captopril? Captopril, guys, is a prototype drug. We are not using captopril clinically. We are using other ACE inhibitors. Now, even if it is not given, even if you are going to consider, sir, have to ACE inhibitor, theoretically to karega, definitely karega. But look at the other option, reduce further enlargement. Reduce further enlargement. The only drug, if you are going to compare between the both, that can reduce further enlargement. In fact, beta blockers, they have shown to reverse the remodeling. They have shown to reverse the remodeling. Hai na? So in one group of people, they give ACE inhibitor only. In other group of people, they give ACE inhibitor with the beta blocker. In the group where the beta blocker was added, there was reversal. Hai na? Carvedilol have multiple benefit. One is definitely it's a beta blocker. It's a alpha 1 blocking property. Therefore, they are having vasodilating property, right? And they are also having antioxidant property. Antioxidant property. So among the given choices, if you have to choose one, I would strongly say that go ahead with the carvedilol rather than going with the captopril. We are not clinically using captopril, no. So this question will definitely be out of the scene, and we are going to utilize a drug here, carvedilol. Carvedilol is the one that is having antioxidant property, vasodilating property. Therefore, preload and afterload will decrease, and we are also going to utilize carvedilol because it's a beta blocker. They will inhibit the activation of the entire RAS system. Okay, oxygen consumption ko bhi they will also reduce. So if you have to choose one, I would say go ahead with the carvedilol. S3 Gallop and Rails mentioned. Okay, and Rails in this system. Okay, Dr. King Ella, S3 Gallop and Rails still going to be carvedilol, because captopril again we not use clinically. Now, next one that we are having is drug binding to ATP binding cassette. So, P-glycoprotein, if you have read, you already know that there are some agents that are inhibiting ATP binding cassette, जिसको हम ABC भी बोलते हैं. And correct answer for this one was very straightforward, verapamil. There are many drugs that can inhibit this ATP binding cassette, drugs like your amiodarone, clarithromycin, verapamil, quinidine, ketoconazole. So, these are again the same drug that are coming from the list of enzyme inhibitor. Remember the enzyme inhibitor drugs like peacock wala aayega, inhibit karke jayega. They are coming from the same like clarithromycin, amiodarone, verapamil. They are all, and also valproate. Valproate can also be acting as an inhibitor of the P-glycoprotein. So among the given choices, I would say strongly go ahead with the verapamil. In addition to that, remember cyclosporine can also be one of the inhibitor. Cyclosporine is also one of the inhibitor, not tacrolimus, but cyclosporine is also an inhibitor, not the, they both are calcineurin inhibitor actually. They both are calcineurin inhibitor. We are having tacrolimus is not an inhibitor, but cyclosporine yes. Okay. Next one. Which of the following is avoided in a patient with a thyroid storm? Thyroid storm mein propranolol is the first drug. Propylthiouracil is considered the drug of choice. Lugol's iodine, definitely they are going to inhibit the secretion of the thyroid hormone. Inhibit the thyroid hormone secretion. So in a patient with the thyroid storm, definitely we can utilize Lugol's iodine as well. Add-on drug we can utilize. Aspirin that we have is not going to be utilized. Aspirin will be causing dissociation between the thyroid, dissociation between the thyroid hormone with its binding protein. H for hormone, B for binding protein. So if you are going to give your drug aspirin, aspirin is going to create a dissociation between these two. Now this one will be further causing worsening of the problem, worsening of the problem. So if the examiner is going to ask you what is to be avoided in the given choices, I would say that aspirin, PTU not, they give paracetamol. Okay, so let us say that there was paracetamol. If there is paracetamol, remember paracetamol is not avoided. Paracetamol is not avoided. The drug of choice, if the examiner is going to ask you drug of choice for thyroid storm, we are going to use propylthiouracil, PTU, propylthiouracil, thyroid storm के लिए drug of choice होगा, right? And if paracetamol is given, paracetamol is not avoided. Aspirin is something that is going to cause dissociation from the hormone and its binding protein. Triangle one is the binding protein. So if the hormone will be free, they will be causing worsening of the problem. So we should be avoiding them. Okay. Okay, was there a question on ampicillin therapy and pseudomembranous colitis? A patient is presenting and coming to you, he is on ampicillin therapy. So ampicillin therapy or cephalosporin therapy amphitherin, cephalosporin, they are going to be associated with the risk of pseudomembranous colitis. And in that condition, fidaxomicin is the most preferred agent. In the upcoming examination, examiner, they can ask you which class of drug is fidaxomicin. So they are macrolides. Examiner asks, what are the other agent? What are other agent? मेडविसन, डॉग, एस्पिरिन हर जगह दिक्कत देती है. डेफिनेटली एस्पिरिन विल इनहिबिट द यूरिक एसिड एक्सक्रीशन एज वेल, एंड एस्पिरिन सबसे ज़्यादा दिक्कत देती है वाइवा में. If you are one of the second year student and sitting in the viva and you said that I read COX inhibitor or I read aspirin, the examiner is going to take the huge advantage of yours. So say everything I have read but never say aspirin, because aspirin is a topic from where examiner loves to ask question. So it's the most troublesome drug I have so far I have experienced in viva as well. Okay. Other agent that we can use is per orum vancomycin. If it is mild cases of pseudomembranous colitis, we can still use metronidazole. If you remember recently on my Insta as well, I posted a question about a monoclonal antibody, which is possibly going to be the next exam question, because pseudomembranous colitis is repeatedly being asked. So next exam question the examiner can ask, which is the recently approved monoclonal antibody. So recently approved monoclonal antibody is going to be your bezlotoxumab. Bezlotoxumab, you check out this bezlotoxumab, we have discussed already in our lectures as well, and in our question answer series as well we have discussed, right? So this is one of the monoclonal antibody against Clostridium difficile toxin B. Against Clostridium difficile toxin B. Bezlotoxumab is one of the monoclonal antibody against Clostridium difficile toxin B. This could be your next question. So again, bezlotoxumab, toxin B के against, toxin B of what? Clostridium difficile, right? So correct answer, I think other option, if you guys can remember, can you guys give me the other option if you guys can recall? Most preferred drug, can you guys give me other option if you can recall? Other option was there, metronidazole, okay. Dr. Sumaya Fatima, metronidazole was there in the option, I am considering this as an option. Other option? Alright, so I would just wait for your comment here for the other option, and we are done here. I have one last question here, and this question, that last question that I saved here, is actually not supposed to be asked because it's not a part of your usual discussion. We usually do not discuss because this is something which is given to pharma postgraduate resident for inducing the inflammation. So it is an inflammation causing drug, carrageenan. It is one of the inflammation causing agent, that is causing your paw edema, है ना. तो peripheral kind of pain inducing के लिए इसको use करते हैं. We use it for peripheral pain. So you guys can let me know what was the option here. There is a lag between what I am saying and what you guys are commenting. That's why there is an issue here. Some of you are telling, sir, novobiocin was the option. Okay. Let me remove metronidazole and tell you that novobiocin, okay, novobiocin is one of the option. Other option you guys can let me know. Okay, so I'll take last 60 second and I'll take all the 24 or 25 question luckily I got here. So एक बार quickly देख लेते हैं क्या 24 question था. जितने लोग last में join किए, all the students those who have joined late, you are not going to miss anything. Just stay for 60 second and we are quickly going to go ahead with all those questions. Noxious acute stimulus. So this is one inflammation causing agent, so definitely they are noxious only. They are mainly used for inducing paw edema in the animal model of inflammation. Okay. If this was the one, then this is going to be the preferred answer here. This is going to be the preferred answer. Dr. Sumaya Fatima, if this is the one, this is going to be the correct answer. Peripheral pain, peripheral or deep pain, this is going to be the correct one, right? So let me quickly go ahead with all the 25 questions that we are having. 60 second quick recap. Carrageenan causing peripheral deep pain, this is one of the question. Then fidaxomicin, it's one of the agent that is a most preferred drug for pseudomembranous colitis. Next question was there about avoided in thyroid storm. Aspirin we are not giving in thyroid storm. Aspirin is avoided in patient with the thyroid storm. Next that we are having is ATP binding cassette के साथ bind करके the drug that will be working is known as your verapamil. Next that we are having is about congestive heart failure patient with cardiac enlargement which can reduce further enlargement. Among captopril, carvedilol, I would say prefer your carvedilol. It's most noble drug and definitely AIIMS and INI-CET में तो multiple paper, multiple conferences में, multiple studies में, multiple time ये discuss हो चुका है इनके institutes में. ठीक है. Then about not sensitive, remember Candida, glabrata and crucei not sensitive to fluconazole. If it is anything is not sensitive to fluconazole, then we are going to prefer amphotericin B. Next that we are having diabetic neuropathy. What we are going to use is your pregabalin. A child with history of iron, if the level is more than 500, we are going to start the management. Site of action of valproate, it will be inhibiting SSA dehydrogenase and GABA transaminase. That is how they are going to increase the level of your GABA. Next that we are having is pinpoint pupil, morphine will be the correct answer. IgM and scrub typhus, I would strongly recommend go ahead with the doxy and azithromycin if both combination are given. Then we are having more common with oxcarbazepine compared to carbamazepine. So hyponatremia is more common with the oxcarbazepine as compared to carbamazepine. Then 55-year-old with hypertension, first drug that you are going to start, I would say that you start with ACE inhibitor, ARB, or if the age is 55 or more than 55, you are going to start calcium channel blocker. So here calcium channel blocker is amlodipine that we are going to start. Next that we are having MDR TB, next line of management. So TB is the bigger problem here. So we are going to continue the anti-tubercular therapy and add uric acid. However, if the hepatic enzyme is significantly very much high, then in that case scenario, we would always recommend to stop pyrazinamide and continue the therapy of your isoniazid rifampicin for 9 months. Isoniazid rifampicin ethambutol for 9 months. The screenshot of Goodman-Gilman I have given here already. You can check it out. If there is slight change in the language, you can correct according to what was the language of question. Okay. Which of the following protease inhibitor maximally? So ritonavir, as I have given you already. If ritonavir is there, nothing will be the answer. TCA में hypothermia नहीं होगा. TCA poisoning में there can be all others but no hypothermia. Then we are having here anti-diabetic agent approved for heart failure with the reduced ejection fraction if empagliflozin was in the option. So empagliflozin will be the answer. Don't be confused with the DPP4 inhibitor safe in renal failure. In this question also according to a student they said sir renal failure ka component tha. I agree, but examiner didn't ask which anti-diabetic drug is used in a diabetic patient in renal failure component. They ask for the heart failure patient which anti-diabetic. So two drug always come into our notice, liraglutide and empagliflozin. Empagliflozin was in the option. This is going to be the correct answer. Fostamatinib for idiopathic thrombocytopenic purpura, I already told you this one. Next one is going to be sodium valproate, is going to the most hepatotoxic one. It can be utilized as an anti-epileptic, definitely it's a mood stabilizer agent as well. Cardiotoxic agent hai, if you are going to prevent the cardiotoxicity, I told you dexrazoxane, they are the iron chelating agent. Other option I have already explained in more detail. Ethionamide is something that will be causing hypothyroidism, anti-tubercular drug, two drug causing hypothyroidism, ethionamide and para-aminosalicylic acid. And the first question that we are having is which of the following drug is going to be preferred in a patient who is orally not able to tolerate the drug. Rivastigmine available by the transdermal patch, we are going to prefer this, right? So with this one we are done with our pharmacology session. Thank you very much. For any more doubts, for any more query, feel free to message and you can search out, you can tag in all the social media platform as well if you want to get any of your queries sorted. You can also download the PDF of this one on the Telegram group of NExT. Thank you very much to all of you. Have a great day.